I start, sir?
Yeah, please go ahead.
Yes, sir. ICU scoring systems can be divided as first day or on day of admission scoring and repetitive scoring systems.
Very
In
good.
the first day or day of admission scoring, we have Apache score, whereas scores like SOFA score and Glasgow Coma scale will be in repetitive scoring systems. Moving on to Apache score. Apache stands for Acute Physiology, Age and Chronic Health Evaluation Score. It is an ICU mortality prediction score which takes both the acute and chronic disease status of the patient into account. There are 4 models of Apache which have been developed till date. Apache 1, 2, 3 and 4, of which only 2 is widely accepted and used nowadays. Apache 1 was developed in 1981 by Dr. Noss, but it has many variables which had to be fed into the computer to get the score, which was difficult in that time. So they refined Apache 1 score to create Apache 2. The number of variables was decreased to 12 variables, and the score can be easily calculated on a single sheet of paper quickly, and it is very easy to use in the ICUs. Apache 2 score was refined further into Apache 3 and 4, which had more variables, but they are not used nowadays because the statistical method is still under copyright control. So in depth, we have to know about Apache 2. Apache 2 is most widely used. It is an admission score and it predicts the severity of the disease when the patient is admitted in the first initial ICU admission. We do not take into account patients who are transferred from other units or from other hospitals after the initial admission, because this can cause lead time bias. Apache score is not recalculated during the stay of the patient. It is not meant to show the improvement or effectiveness of the interventions done in the ICU. If a patient is discharged from the ICU and then readmitted, Apache 2 is recalculated only then. Apache score is not validated for use in patients less than 16 years of age and in pediatric patients. It is a point-based score with range from 0 to 71. Higher score means more severe disease and higher risk of death. Advantages of Apache score are: it helps in the risk stratification of acutely ill patients to decide the aggressiveness of care needed in the ICU. It helps with prognostication of the patients and helps in comparing the care received by patients with similar Apache risk scores in the ICU. Disadvantage is that it does not influence or decide the medical management that the patient is going to receive. Moving on to the components of Apache 2 score, there are 3 parts: acute physiological score, age, and chronic health score. Under acute physiological score, there are 12 variables, which include 5 variables which are on examination, 5 variables from venous blood sample, and 2 variables from arterial blood sample. The 5 on examination signs are rectal temperature, heart rate, respiratory rate, mean arterial pressure, and Glasgow Coma scale. From venous blood sample, we can derive hematocrit, WBC count, serum sodium, serum potassium, and creatinine. And this creatinine score, it has double points if a patient is in acute renal failure. If a patient is in chronic renal failure and they have a score of +2 for the creatinine, the same creatinine value will have +4 if the patient has acute renal failure. And the values which are derived from arterial blood gas are blood pH and PaO2. In total, 12 variables are there in acute physiological score. On admission, if the patient's values can be taken, or the worst values during the initial 24 hours of admission in ICU are taken. And moving on to age, according to the patient's age, if a patient is age less than 44, 0 points are given, and more than 74 age, patient is given 6 points in the Apache score. Then chronic health points. If a patient has history of severe organ system insufficiency or is immunocompromised, points are awarded accordingly. For example, in severe organ system insufficiency, if patient has liver cirrhosis, biopsy proven liver cirrhosis, portal hypertension, past episodes of upper GI bleed, and NIHA class 4 heart failure, severe respiratory disease, or if the patient is dialysis dependent. In case of immunocompromised patients, if patient is receiving chemotherapy, history of radiation, high dose steroid therapy, advanced leukemia, lymphoma, or AIDS, then we give points as follows. We give 5 points if the patient is non-operative or emergency post-operative patient with the above history, and we give 2 points if the patient is elective post-operative patient who is either severely organ system compromised or immunocompromised. After giving points for all these 3 scores, that is acute physiological with 12 variables, age, and chronic health score depending on their immunocompromised status, they are added up and approximated with the mortality rates given in the Apache score.
Very good. Fantastic. It's a very, very clearly prepared and expressed answer. So the first and foremost point about Apache score you all have to know is it is a score used in critical care. Whenever a patient is admitted to ICU or CCU, at the time of admission, we use this Apache score to decide what will be the morbidity or mortality in that patient, whether we can definitely salvage the patient or it's likely to be a failure to save the patient. That can be decided by taking into consideration the acute physiological changes that has taken place in the patient along with the earlier comorbidities or the deformities or he has already had. Based on that, we can decide that. So this will help to plan our line of treatment and also decide whether we are going to succeed in saving the patient or not, and unnecessarily spending all the resources of the patient as well as the hospital in wasting time to save the patient. Okay, that can be decided at the time of admission itself, and that is the reason for that. So you have nicely mentioned that, and initially it had, as you said, 34 variables which were not practically useful or cannot be easily calculated. Then Apache 2 came, which had only 12 variables, as you nicely classified them into clinical oriented, venous blood gas sample oriented, arterial blood gas sample, arterial blood sample oriented, and that is the most commonly used. Then uh, based on the changes in the comorbidities occurring in the patient, they change the classification from 2 to 3 and 4 based on that, and also based on the GCS score which is involved after trauma or the tumor in the brain. So that is the reason why they have to incorporate or include advanced guidelines, just like changing the basic ACLS and BLS guidelines every 2 to 3 years or 5 years. This Apache score also was revised several times to incorporate or include the conditions which were diagnosed or which the patients were coming to get admitted in ICUs. That is the reason why you had the other editions or other advancements or recent improvements in the Apache score system like 2, 3, 4, etc. So without wasting time, I'll just share my screen to show you what she nicely described as